depending on where you are joining us from in the world. My name is Wayne Musabayana. I'm Head of Communication at the African Union Commission. And we are here with Dr. John Nkengasong for the usual Thursday morning brief on the COVID-19 situation in Africa. So today we will have Dr. John's briefing as usual, and that will be followed by another briefing from Mr. Strive Masiwa, who is the African Union Special Envoy on COVID-19 and is also the coordinator of the African Vaccine Acquisition Trust, and that is abbreviated as AVAT. And he will be joining us to speak about vaccine acquisition and distribution on the continent. So when we get to our question and answer section, please utilize the WhatsApp number +251 94 550 2310. I'll come back with that number again, +251 94 550 2310. That's for the time when we come to the question and answer section, at which point you can also come through live or use the question and answer session on the Zoom platform. All right, it's time for us to have our briefing from Dr. John, and he's on standby. Dr. John, you have the floor. A very good morning to you.
Thank you, Wayne, and good morning to everyone who has joined the platform. At this time, I would share with you, as always, during our weekly briefing, the situation of the COVID on the continent. So I was told I was not on mic. So good morning again to everybody who has joined the platform, and a very warm welcome from the Africa Centers for Disease Control and Prevention in Addis Ababa. As always, I would divide my presentation into three parts. First of all, give you an update on the epidemiological situation, and then discuss what Africa CDC is doing to support the pandemic, and conclude with very briefly on vaccine and vaccination situation on the continent. As Wayne said, Mr. Strive Masiwa, who is the special envoy for the can you take that call, please? For the African Union, will be joining us as well. And he will be joining us to give you more updates on the vaccine situation from the AVAC perspective. So let's start with the epidemiological situation. As of September 2nd, 2021, over 7.8 million cases of COVID-19 have been reported on the continent. Of that number, 6.9 million have recovered fully. Our death rates, unfortunately, stands at 197,000 people who have died. And this accounts for 4.4% of the overall global deaths. '75 member states, or 41 countries, are now experiencing a third wave. 31 of the 41 countries, that is 76% of our member states, are experiencing a more severe third wave than we saw in the second wave. Since the last briefing, 3 additional member states, that is Congo Republic, Sao Tome and Principe, and Togo, are now experiencing a third wave. 6 countries, Algeria, Benin, Kenya, Mauritius, Somalia, and Tunisia, are now experiencing a fourth wave, with 67% experiencing a more severe wave. So since the last briefing, 2 additional member states, namely Benin and Mauritius, have now joined the countries experiencing the fourth wave. The situation with the variant continues to be concerning. 43 countries are now reporting the Alpha variant. 37 countries are reporting the Beta variant, and 35 countries are now reporting the Delta variant. 3 additional member states, that is Guinea, Guinea-Bissau, and Niger, have now reported the variant. And we have a full list of all the countries to share with you if need be. So let us now look at the trends. And we start, as always, with the 4 week, 1 week trend, and then we look at the 4 weeks trend. So between the dates of August 23rd and August 29th, we have recorded as a continent 211,000 new cases of COVID-19, and this represents a 12% decrease from the previous week. The highest proportion of new cases are coming from Southern African region, which represents 43%, 38% from Northern Africa, 11% from East Africa, 7% from Western Africa, and 1% from Central Africa. If you look at the new rates of infections and you normalize them by the population per 1 million, it gives you a very different picture, where Seychelles now comes top with 3 new cases: Botswana, Mauritius, Eswatini, and Tunisia. So that is standardizing by population. In terms of new deaths, a total of 5,345 new deaths have been recorded across the continent. This represents, I beg your pardon, 4% decrease in number of new deaths compared to the previous week. So let us now look at the situation with the testing on the continent, because testing is critical. As we speak, the continent has conducted over 66 million tests, and over the last week, they conducted 1.5 million new tests. And despite that amount, it still represents a 3% decrease in the number of tests. We always emphasize the testing because testing is the cornerstone on which we are going to continue to find the cases and understand where we are with the pandemic. The positivity rate continues to be high and remains at 11.7%, with a test per case ratio of 8.5. 18 member states are reporting a daily positivity rate higher than 12. Let me just then conclude by giving you an update on the first part of the vaccine briefing. As we speak today, the continent has acquired 137 million doses of vaccines in 53 member states. Of that number, 104.2 million COVID vaccine doses have been administered, representing about 76% of the total supply available. I insist on that number because it's significant that we have, that everybody knows that we are making good progress with respect to doses available and doses usage. The total coverage, that is the number of people that have received their full immunization as of today, is about 2.93%. 2.93%. That is up from last week. If you recall, last week we were around 2.5%. We are about 2.93% this week. And I continue to be encouraged that countries are making very good progress, some of them. Morocco's percentage of population that is fully immunized now is around 40%. South Africa has increased significantly over the last couple of weeks to about 14.7%. Egypt stands at 3%. Tunisia stands at 12.78%, and Zimbabwe about 11%. So the more the vaccines come in, the more countries are using the vaccines out, and our full coverage rate continues to increase. Last week, we mentioned that 2 countries, Eritrea and Burundi, still were not engaging in acquiring vaccines, but I'm happy to announce that Burundi has now engaged the AVAC, that is the African Vaccine Acquisition Task Team, to acquire its vaccines. France has committed to sharing at least 10 million doses of AstraZeneca vaccines before the end of 2021. The initial allocation of 10 million doses were to arrive in tranches in August, 5 million, and October, 5 million. So we are grateful for that contribution. I would also like to add that the first 5 million for 22 member states is being donated through the AVAC mechanism, and of course the distribution will be done by UNICEF in close coordination with the AVAC. And lastly, I would like to end on this note that the third batch of distribution for the AVAC doses have started, and 6 African Union member states already confirmed 800,000 doses of Johnson & Johnson, that is Sierra Leone, Ghana, Rwanda, Kenya, Cote d'Ivoire, and Conakry. But I would like to keep that short because Mr. Strive Masiwa, who is the special envoy for COVID in Africa and coordinating the AVAD process, is on, and I would like to, without further ado, turn it back to Wayne so that you can introduce Mr. Masiwa. Over to you.
Thank you very much. That was the briefing from the Director of the Africa Centers for Disease Control and Prevention, Dr. John Nkengasong. It's time now for us to invite Mr. Strive Masiwa. I have introduced him before, but let me just repeat again that he is the AU Special Envoy on COVID-19, and he's also the coordinator of the Africa Vaccine Acquisition Trust. And he's here today to talk to us on the issue of vaccines, vaccine acquisition and distribution. Mr. Masiwa, good morning, and please go ahead with your brief.
Good morning, everybody. Good morning, John and Gwen. Thank you. Great to see you this morning. As John has we spoken before, so I will not give too much of a historical context. As you are all aware, the African Union's stated objective is to vaccinate 60% of the population. Under the agreement with the donor community, the COVAX initiative is meant to vaccinate 30% of our population. So the Africa Vaccine Acquisition Trust was set up by the leadership of the African Union as a mechanism to purchase the other 30% that is required to bring us to the 60%. So I'm a member of a task force chaired by President Ramaphosa of South Africa, whose task it is to engage manufacturers directly for the purpose of purchasing vaccines. We raise money and we buy vaccines. I've spoken before about some of our challenges, and I'm not going to relitigate that. Basically, where we are is we have purchased 400 million doses of the Johnson & Johnson vaccine. Since it's a single shot vaccine, it's enough to vaccinate 400 million people. Let me repeat that. It's enough to vaccinate 400 million people. And if you do your calculations based on a population of 1.3 billion people, that is exactly 30% of our population. So if the donor community through the COVAX initiative delivers on its 30% commitment, we would achieve our 60% target by September next year. The AVAT 400 million vaccines were purchased from the US company Johnson & Johnson. As you all know, production capacity does not allow you to immediately receive 400 million doses. I wish it were possible, but it's not possible. No one can. So our shipments are stretched out over 12 months. and as I've shown to you before in slides, our shipments were set to begin in August and will proceed all the way to September next year as more and more volumes begin. And I will touch now on the shipments. So our agreement with Johnson & Johnson is that they would start producing, the vaccines would be produced and shipped from South Africa at a plant in Port Elizabeth called Aspen, and that we would then distribute on a month-by-month basis. The start date under the agreement was August. So in August, we shipped to 27 African countries and 6 Caribbean countries, because the Caribbean countries are part of AVAT. They were invited by the African leadership because they were struggling to also get vaccines. So we worked together. So this month, I'm pleased to say we shipped 6.4 million doses in the August month, the month that's just gone. And that's part of what John was referring to. These are ongoing shipments going through. They have been going through very smoothly for the first month. In the month of September, we jump up quite considerably. We are planning to ship 20 million doses this month, and we are well on target. And we will, the number of African countries that will receive doses in September is 41 countries. These are countries that have purchased the vaccines. They are not free, they have purchased their vaccines. We purchased the vaccines at exactly the same price as COVAX. We coordinate on pricing with COVAX. So there is no price difference at all. So we will ship to 41 African countries in the month of September. We hope that by the end of October, the number of countries purchasing vaccines will have increased to about 45, 46, because there are a number of countries that are self-provisioning, that are not purchasing through AVAT. But the vast majority are purchasing through AVAT. I'm also pleased to inform you that the World Bank and AVAT have been working extremely closely. So in terms of our financing, Afri-Exim Bank, which is owned by the member states, put up a bank guarantee of $2 billion to enable us to purchase the vaccines upfront. The World Bank then put up a facility of up to $4 billion for the member states of Africa, for 41 member states that need funding to purchase vaccines. And this is made up of concessional financing for poorer countries, et cetera, et cetera. And we have a working group with the World Bank that meets every single week, working through with the countries that have purchased vaccines, that want vaccines, giving them the facilities that they need. And that is working very, very smoothly. We meet once a month with the World Bank and the African Ministers of Finance and Afri-Exim Bank and all the health ministers. Our next meeting is scheduled for next week. This is really the overarching authority under which AVAT operates. So the ministers tell us what they need, the finance ministers and so forth. That mechanism is now working very, very smoothly. And we're very appreciative of that. So the funding to purchase vaccines is in place. The vaccines from a purchasing point of view are in place. We will hold the 20 million or so vaccine delivery on a month-by-month basis. The countries know. We will continue on this basis all the way to December. And then after December, Aspen will bring in a new production line for an additional 170 million doses a year. Once that production line is triggered, we hope to be at about 40 million doses a month by January. So these are directly purchased vaccines, and that should begin to really accelerate our own commitment in this partnership as African member states. Now, let me turn my attention to the donor side. And I also want to address a controversial issue which some of you have read in the last few weeks, which is this arrangement whereby between Johnson & Johnson, whereby vaccines produced in South Africa were also going to Europe. You've read it, and I won't comment beyond saying this. That arrangement has been suspended. Our leadership, led by President Ramaphosa, we met with the European leadership and President von der Leyen, who wasn't aware of the arrangement, reversed it immediately. All the vaccines produced at Aspen will stay in Africa and will be distributed to Africa. And it's part of the reason that we are now able to ship more vaccines directly from the facility. All vaccines from that facility are under the control now of the South African government, which has committed that those vaccines will go to Africa. In addition, President von der Leyen met with President Ramaphosa last week, and I'm sure in Berlin, and we had a very extensive discussion around the issue of vaccines. And she also undertook that vaccines that had been shipped would be sent back. And we expect to see the first of those vaccines given to us this month. In addition, the Europeans committed to give us 200 million doses before the end of December. This is a very, very major commitment, and we are now working with the European partners. We are, as you have heard, the French were the first to step forward. We're very grateful to President Macron for his very quick action once this issue emerged. The leadership in Europe were not aware. And so this issue has been corrected, and it has been corrected in a very positive way. And I want to be specific. The Europeans have committed that drug substance produced in Europe at the Leiden facility in the Netherlands will continue to be shipped to the Aspen facility, processed at the Aspen facility, bottled there for Africa. And there's a commitment of 400, that we have enough drug substance for the entire 400 million shipment. So we do not, even if there's a problem of the emergent facility in the United States, and we are not currently taking a drug substance from the United States, our drug substance was switched to Europe. And the Europeans have committed that we will continue to get the drug substance, as well as be allowed to keep all the production that comes from that drug substance. There will be no sharing. So I'm very pleased about this. And I'm very grateful to European colleagues. The French have committed 60 million doses. These 60 million doses are part of the 200 million that Europe has committed. The Germans have committed 70 million doses. They're part of the 200 million. So I need to be clear about that. My understanding is that it's 200 million, but Germany and France have stepped forward to engage us directly. This week, we issued the joint press statement with the French government, and we have now got a working party with the French government and COVAX, as well as UNICEF. And the first shipments of the French doses are already on the move. So we have no reason to believe that the French commitment, that the European commitment will not be met. So we are working on this. This should see a dramatic shift in the delivery of vaccines. Now, is it enough? No, it's not enough. We still need a lot more vaccines than 200 million. But this is extremely important. Our total requirement in a double dose regime is 1.6 billion doses to get, if we were doing it with vaccines that require a double dose. So I hope I have good news coming out of Europe. We are very pleased and we're very grateful to President Ramaphosa in particular for his very hands-on approach to resolving this problem. One of the critical things that we have addressed arising from the confusion between Johnson & Johnson and the Europeans and Aspen. When this issue came up, the president asked, we needed to understand why it was possible that vaccines had left Aspen without us knowing, really, as it were. And the reason is very simple. Aspen has been operating as a contract manufacturer to Johnson & Johnson. So Johnson & Johnson is in complete control of the production process and the delivery process. The South African company has no say over that arrangement because it's a contract manufacturer. Once this became clear, the president then said that that arrangement should be changed. So the way to change that is for Aspen to get a license, to become a licensed manufacturer, similar to Serum Institute with what's the Swedish company? It'll come back to me just now. Okay, AstraZeneca. Okay, so that is a licensed arrangement. It's not a contract manufacturer. So this morning, a statement was issued by Aspen and Johnson & Johnson, confirming that they are moving their relationship to a licensed arrangement. So the plan is that if they successfully negotiate the licensing between them, we can't force them, but we've made it clear that that is what we want. A licensed arrangement will mean that the product will now be produced as an Aspen product under a license from Johnson & Johnson. And it will become an African branded product. On top of that, the president has asked Johnson & Johnson that the relationship also include drug substance production. That's a much more long-term process, but it could be achieved in the next 3 years, we believe, our own experts. And Johnson & Johnson have shown have been very positive in that request. But for now, we will leave them to the commercial arrangement of a licensed product. So by the time we get to January, we hope that what will be coming through is a licensed product. So now let me also turn my attention to other conversations with donors. So let me just point out that although as AVAT, we have our main interest is to buy vaccines. As special envoy, my interest is overarching. I'm interested in all vaccines coming to Africa. That's my job, is making sure that all vaccines come. And so I have been putting, hopefully, a fair amount of pressure on COVAX, demanding that the commitments that were made be fulfilled. And we have been holding numerous meetings with both COVAX, WHO, UNICEF, to try and improve the situation. And I'm encouraged, let me say this, I'm encouraged. The attitude is very good. We're making progress. I think that September, October should unlock this logjam around why we had a situation where they've secured 2.4 billion doses, but have only delivered 30 million. Okay, so naturally we are alarmed by that, as is the rest of the world, because it meant that vaccines, the almost 300 million vaccines we expected by August were not delivered. We got 10% of that. So we're working extremely hard to try and fix that. John and I will travel to Geneva next week for talks. And hopefully at our next press conference, we will have some good news. But I'm also grateful there to Dr. Seth Barkley and his team, because these are not, we're not here to blame people. We want to solve problems. So we've been working together extremely well. So as part of that partnership of trying to work together to unlock the vaccines, we're working together with the French donated vaccines, the European donated vaccines. We're working with them on the American vaccines, and I'll close with the American vaccines. The United States has so far donated 25 million doses, and those have mostly now been delivered. They were delivered through August. There are still shipments coming through. We are now beginning to get shipments from the United States as part of their donation of Pfizer vaccines. Now, the US, as you will recall, made a global commitment of 500 million doses, Pfizer vaccines. Whilst they have not given us yet a definitive number of what share Africa has of those Pfizer vaccines, we have been working on the basis that Africa should get at least half of that, given that more than half of the COVAX countries are African. So with that in mind, we are expecting 60 million Pfizer vaccines to be shipped before Christmas. Okay? So if you do the numbers, let me summarize. If you do the numbers, the Europeans have a commitment to deliver at least 200 million doses by December. About 70 million doses will come from the AVAT purchasing, including those directly purchased by the government of South Africa. It should be about 70 million, okay? And those are single dose. I can't break down the European doses yet as to what is Johnson & Johnson and what is AstraZeneca and Pfizer at this time. But there is a considerable amount of Johnson & Johnson in the European shipments. So it's 70 million from the African side directly purchased, and then an additional 200 million from Europe. The Americans, we expect about 100 million over the same period. So you can run the numbers yourself. That's 370 million doses, circa, for this period, okay? COVAX themselves have purchased vaccines. We believe, we have been notified that they have purchased Sinopharm vaccines, which will begin to arrive in September. We expect about 100 million Sinopharm vaccines to come through COVAX during this period. The shipments out of India remain blocked, which is primarily where COVAX purchased vaccines from. And that there are no vaccines really coming out of India at this stage that we've been notified about. I'm not here to speak for COVAX, so you can go to their press conference and find out what the data looks like from their perspective. But I'm giving you an overarching picture of how we are looking at it, okay? I think I have covered most of the issues. I won't be able to stay today for much of your question and answer because I have another commitment. But I thank you for listening. I thank you, my colleague, Dr. John. He's looking very sharp. He's kicked COVID now, but he's now a veteran, so he tells us from the inside how deadly this thing is. And once again, I appreciate the work of John and our colleagues from Africa Exim Bank. They've done much of the heavy lifting to make it possible for us to be where we are. Thank you very much.
Thank you very much, Mr. Strive Masiwa, the coordinator of the Africa Vaccine Acquisition Trust, AVAT. Dr. John, you have a few comments.
No, thank you, Wayne. And before Strive goes, let me just make this comment, which I believe we have not amplified it enough. I think Strive mentioned our needs. When you're fighting a battle, you know exactly what your goal is. We have established a target of 1.6 billion doses of vaccines. And the fact that through the AVAC process, as a continent, we have secured the equivalent of 800 million doses of vaccines. If you translate the Johnson & Johnson vaccines into the equivalent of the 2 doses, there is significant. And that story must be told. I personally, as I've been in public health for 3 decades, never in the history of our continent in fighting infectious diseases, I've seen this kind of the power of what I call the power of unity of purpose, where Strive Masiwa from the business side as a special envoy, Vera Songwe as an economist from the UN Economic Commission for Africa, and Professor Benedict Orama from the banking. We all led by President Cyril Ramaphosa, who is the COVID champion political leader, all coming together to solve a problem that is an existential threat for our continent. I don't think that piece has been highlighted and captured enough. We tend to talk more about a donation of 10 million here, which we are very grateful, 5 million, or what COVAX was supposed to. The real stuff is what Strive just explained here. I think when the history of this pandemic will be written, and I'm very sure it will be written, just as the history of the 1918 pandemic was written, I hope that those who will record it will record that these are true heroes that stood up and took the destiny of our continent into their hands to solve a huge problem that, as I said, is an existential problem for our continent. So it is really, I lack words of gratitude of expression to this remarkable partnership and leadership by Strive, President Ramaphosa, Dr. Vera Songwe, Professor Benedict Orama. So Strive, thank you so much as you you go. Left to us as public health experts, we would know how to define what the problem is, characterize it, but we would definitely not be able to engage in a way and find the solutions as Strive has described to you all. So I just wanted to make that remark before we open up for questions.
Yes, indeed. Thank you very much. Let me thank Mr. Strive Masiwa for that very comprehensive brief on what Africa has done to make sure that the continent has vaccines that will help us past this pandemic. We now move on to our question and answer section, and the first two questions are coming from Sydney Kawadza, and Sydney is the editor of the Anchor magazine. So he says, one of my observations during research has been the lack of information about the virus, especially in rural communities, and especially to the disadvantaged, the visually impaired, and speech impaired. So then come his two questions. So he says, what are the information dissemination programs across the continent to cover the vulnerable members of the African society, and how effective have those been? That's the first one. And then secondly, he asks, what can African states do to improve information dissemination in light of the prevalence of fake news, and especially given the advent of social media? So those are two questions coming from Sydney.
No, thank you so much. I think those are very important questions. And in terms of communication, I believe as Africa CDC, we are doing a lot. Our communication team is reaching out tremendously. And the component, that aspect you bring that speaks to the vulnerable population is something that has caught my attention as you discuss it, and we'll be more than happy to find ways to engage in that, because again, we are learning in this process, and as we go forward, this is a new virus, it's a new disease, and you're absolutely right that we need to continue to improve the way that we use social media. This is the first time that we are fighting a pandemic alongside social media. When HIV/AIDS pandemic hit us, and other crises like Ebola, the social media was not as prominent as it is in this crisis here. So I think it's a learning curve, and I believe that the next generation of public health experts that will be trained from schools of public health should actually factor in this behavior component and the role of social media in fighting pandemics.
All right, thank you for that. We move on to Addis Getachew, who is the correspondent for Anadolu News Agency in Addis Ababa. And Addis says, my question is on vaccine coverage and is directed to Dr. John. What would be your advice for countries in terms of administering vaccines in an equitable manner? In Ethiopia, it appears that most, if not all, of the available amounts of vaccines are being administered in the cities, particularly in the capital, Addis Ababa. Is it something that you would recommend as the right course of action?
So I have said on this platform that we have to look at, use science to drive the distribution of vaccine and vaccination programs. And the science that we know for this, and the data that we are analyzing at the Africa CDC is clearly that the caseload for this virus is still in major cities. And if you have an enemy somewhere, that is where you go to attack the enemy. So I think it makes sense that we start, a key word here is start. You start in your major cities so that you break the backbone of the transmission there. Infections are coming from the major cities to the remote areas, okay? And this is where the caseloads are. In Ethiopia, since you mentioned Addis Ababa, 60% to 70% of the infections are still in Addis Ababa. So if you can vaccinate quickly Addis Ababa, and you begin to slow the transmission into the remote areas, and you break the backbone. Then in the remote areas, you do what we call a mopping up operation, where you can actually find out through testing how the virus is spreading, and then you do a targeted vaccination. But my approach, our approach will be target those big cities, vaccinate quickly, and vaccinate at scale. Then you can break the backbone of the virus.
All right, thank you. We go online and we say good morning to Gabrielle Steinhauser from the Wall Street Journal. Gabrielle, please go ahead with your question. Just tell us who it is directed at.
Hi, thank you so much. It's two questions actually for Mr. Masiba, if he's still there. The first one is how many of the J&J doses are being sent back from Europe? And then the second one is about, you mentioned that you think Africa as a whole will receive about 70 million J&J doses by the end of the year. I'm confused by that number because I thought South Africa was supposed to get 30 million and then already going to get 50 million. But then at the same time, if no doses from Aspen are going to Europe anymore, shouldn't that number be going up rather than going down? Thank you.
Thank you so much, Gabrielle. So we look at, in terms of the European vaccines, the Europeans are going to give us 200 million doses, okay? They've given us back what was in the warehouses that had been shipped from Africa. What had been distributed to countries is not an issue for us because we never received, they never took 200 million doses. They took less than 20 million. So in the big picture, if somebody comes and says, listen, we are going to give you 200 million doses and we'll give you whatever back we still have, that's okay with us because 200 million is a pretty good offer on the table. This is their dose sharing plan. It's the biggest that we have received and we are focused on that. We're getting 200 million from them and we are getting we are getting whatever is in their warehouses. We don't have the number yet, okay? But the goodwill gesture is there. So the September shipment is being given back. We are already taking the September shipment. Now let me address the maths for you, the numbers. The South African doses, you are right. The South Africans are supposed to get about 30 million, okay? And Africa is supposed to get about 50 million, okay? The number of vaccines that Europe was supposed to get in September that was still outstanding for Europe. The sharing, the 60-40 sharing arrangement that was in place was only up to the end of September, which is about 8-9 million doses, okay? So that's the only big upside that we pick up because October, November were already our doses. I hope that clears it for you. So give or take, we're about 70 million doses. Yeah, Africa itself is about 70 million and South Africa for that period, they've already been picking up vaccines for earlier periods. So the total number should be about 70 million.
But sorry, just so I have this right, because I remember a few weeks ago, and I think in early August, when you detailed the J&J shipments, you said that Avat was going to get around 50 million this year, and that wasn't going to include the South African shipment. So are the Avat receipts actually declining for the whole year rather than going up, even though the Europeans are sending back some doses? So that I'm just confused by, because for me, 50 plus 30 is 80 rather than 70, right?
Yeah. So you're right. So if you look at Avat itself, okay, what I need to be clear for you is Avat itself is getting 70 million doses, okay? The South Africans are getting about 30, okay, of which most of that they have received, I hope that clarifies it.
Okay,
for
so
you.
the total
look
of the two combined is then 100.
It's then 100, yes.
Okay, great. So,
But the South Africans don't purchase as
Right.
part of a VAT.
okay,
They purchase with a VAT, but they have a separate contract because they decided to work it that way because they are a self-purchasing country.
All right, we need to move on
Sometimes
to someone else
bit of
now.
a con-
Let's now take a question from Sophie Mukwena, who is with SABC. Good morning, Sophie. Please go ahead with your question.
Thanks so much. My question is directed to Dr. Kenkasong. Dr. Kenkasong, South Africa recently reported a new lineage. For now, it's called C12. While there are reports that we can't, for now, say it's a variant, there are issues that we have to monitor to ensure that we don't make a mistake. Now, I want to find out from Africa CDC, did you receive such information? And perhaps, are there other countries on the continent that have reported this lineage? And then to Ntate Masiwa, are we on course really to be able to vaccinate the population on the continent as it was in the Seychelles, looking at these challenges of access to vaccines? I mean, the last time you spoke, there was hope that we are back on track, but all of a sudden, it looks like there's doom and gloom again.
Can I answer you first? Are you talking about doom and gloom in South Africa or doom and gloom in Africa?
In Africa, I mean, in Africa,
Right.
and the death toll in South Africa is just terrible. I mean, 200 people daily. It's sad. I mean, it's sad.
So let me just come back to you on the vaccine side. We are still less than 2% of our population have been vaccinated. And the issue is just access to vaccines. Even if we deliver 370 million doses that we can see by Christmas, okay, that is would still be less. And given, if you assume that only let's say the maths put us at 100 million Johnson & Johnson during that period, okay? And the rest are double dose vaccines. We would still be under 20% of our population covered. The way it is looking, we will only get to that 60% level of our population by about September next year. That is how it is looking, okay? And that would require a consistent delivery of vaccines plus plus the actual vaccination programs being sustained, okay? Now, here's the challenge, as Dr. John will point out. 60% is what we thought last August 2020, would be where this thing would be contained. As you have seen in the United States and Israel, you may not contain it at 60%. The WHO is already urging us to revise our target to 70% of the population. And these are conversations we are due to have with the African leadership, okay? So we will do our best to get the vaccines through, but as to whether we will be able to contain the disease, contain the mutations that are coming through, that I will leave to Dr. John. That's why I thought I would go first.
All right, now we move to Dr. John.
Yeah, thank you, Sophie, for raising the question of the new variant in South Africa, the C12. So, and also thank you for raising the issue of the deaths. It speaks to the seriousness of the situation we are dealing with. My fear, Sophie, is that we collectively, the world is beginning to normalize deaths, where we think it's okay to bury 20 people or 50 people a day and we move on. Let me just be very clear. We have moved past the acute phase of this pandemic. We are in a sustained phase of it, so which means that we have to use a combination approach and not only rely on vaccines, because as Strive has said, we are doing our best possible to get vaccines on the continent. And it will take a while. I would actually put it at the end of 2022 before we can get to a very reasonable average. That is an average of about at least 60% of the population vaccinated. I remain hopeful that if you hear the numbers that Strive mentioned, they are improving, but they are not fast enough. Okay, you're not getting vaccines into the arms of people fast enough to blunt the spread of this virus. The second thing is that we are learning about the biology of this virus and what we call the pathogenesis of this virus, which is initially we thought that if a sizable number of the population is vaccinated, you blunt the spread of it. But now we know that even if you are vaccinated, you can still get infected and you can still transmit the virus, which therefore means that the vaccines are doing what they were supposed to do, which is they were designed to reduce the progression to disease and the severity of the disease, not prevent us from transmitting it there, which means that it justifies what I'm calling for, that we need to begin to think of a comprehensive approach in managing this pandemic and not look at the pandemic still in the acute sense, which says that you detect people, isolate them, and then hope that vaccines will come in. We need to have a very comprehensive long-term view of where we are going with this. So that is very clear. If it's clear in everybody's mind, then we take individual responsibilities. That is not because I get my vaccine that I move around without a mask, that I go around without washing my hands. The vaccines always they do one thing, and I can speak from a personal experience. They will reduce the severity of the disease and also the need for you to go to the hospital. I didn't go to the hospital when I was infected. I stayed home, and after a week or two, I resolved the situation. With respect to the mutation, the C12 mutation, no doubt that many other mutations will arise. The more we delay in vaccinating, the more we increase the ability that new variants will emerge. And I think it's just obvious. What we are seeing is an ecosystem that mirrors the use of antibiotics. If you use antibiotics poorly, you create mutations to the bacteria. Okay, and it's the same thing if we vaccinate slowly, and you see many more mutations happening there. But the good message is this, and I'll end on that, is that the same methods of prevention, public health methods of prevention that we all know and has helped us in going through the first wave, the second and third wave, are the same measures that apply to any mutations or any variants that are emerging there, which means you wear your mask, we wash our hands, we social distance, you avoid large gatherings. If we offer the virus the space to spread, it will spread. There'll be no doubt. So I think I'm less concerned with the emergence of the variants. I'm more concerned with the need to vaccinate quickly. The only way that we win this battle quickly is to vaccinate quickly.
Thank you very much. We move on now to Judith Akolo, who is with the Kenya Broadcasting Corporation in Nairobi. And her question is to Dr. John, and it's about the new variant that was discovered in South Africa. And she asks, how seriously should we be taking this new variant? And also, more importantly, are we seeing a situation where this might get out of hand?
No, sure. As a virologist, I'm expecting that these variants will emerge. I mean, no doubt, Judith. Let me just go off a little bit and talk about HIV. There are at least 12 or so subtypes of HIV. okay, the virus that causes AIDS, and recombinant forms. I've worked 29 years in the area of HIV, but the public doesn't really know about all these subtypes of HIV. They know that HIV causes AIDS, okay? And there are three things that we should be looking at for these variants. One is, are the diagnostics picking up these new variants? The answer is yes. So it means that if somebody is infected, you can act, whether with any kind of variant, you can still detect it. That is very good news. The second question that should bother the public is, are vaccines effective against this variant? And so far, the answer is yes, with some reduction. Okay, like the variant, the Delta variant, you know that it can break through anyone that has been vaccinated. But then, remember what I said, the severity of the disease will still be less. I mean, the chances that you go to the hospital will still be less. So I think that is good news. The third thing is that does the emergence of these new variants increase your ability to die from the virus or no? We don't have enough evidence from that. We know that the new variants, like the Delta variant, transmit more, but it doesn't necessarily mean that they kill you more. Okay, so I think that those are three things that the public should be thinking of. If I'm infected, am I going to be diagnosed? Answer is yes. If I'm infected with a new variant and I have vaccines, would the vaccines protect me? The answer is yes. If I'm infected with a new variant and are there chances that I die because of this new variant more than the wild type virus there? The answer is we still don't know that that is the case. We have not seen that increased mortality from the Beta, the Alpha, and the Delta variant there. So that is what you should be looking at.
Thank you for that. Sarah Jerving, who is with DEVEX, says that Seychelles has the highest percentage of fully vaccinated people on the continent. But why does it now lead the continent in new infections?
Yeah, that is, I mean, remember we had discussed this previously, and it's not just in Seychelles, but in Israel as well. So that is what I'm saying. I'm saying that even though you are vaccinated at scale to 60%, if you still do not implement what we call the public health and social measures, you see those who have been vaccinated become infected. But the good news is that if you have been vaccinated and you get your infection, you will not end up in a hospital. Okay, the gap between, if you see those who are dying because of the infection, is because they have not received their vaccines. Those who have been vaccinated will definitely be infected, like I was infected, but they will not be sick and go to the hospital. That is what we should always remember.
All right, thank you for that. We go to Rodney Muhumuza of the Associated Press. And Rodney has a number of questions, but I will take 2 or 3. So he says, how effective has messaging been overall in overcoming vaccine hesitancy, which remains even an issue among health workers? Then he says, what else can be done to convince more people of the safety of vaccines? And the last question that I will take from him is, should public leaders, including religious leaders, be doing more in this issue of messaging?
So let me start with the last component there, the religious and civil society leaders. They should definitely be doing more. And in the coming days, you see an aggressive campaign from Africa CDC to engage the public and explain this, because we have been a little bit cautious that previously we didn't want to go out there with a strong message and campaign to mobilize the community, because if you do that, you have to be sure that the community knows where to go get their vaccines. But as you heard from Strive, now that we know that vaccines will be coming in a predictable manner, we can now campaign and engage the religious leaders, civil society, and others to engage their communities there. I think that is important. The uptake of vaccine on the continent is everybody's business. Okay, it's not just public health or political leadership, it's everybody's business. We have said that we should sign a social contract with ourselves, a social contract that says, I need to be vaccinated to protect myself, protect my loved ones, and protect my community. That is the social contract that I've been calling on since last week. I think we need to do that with the religious leaders, with the civil societies, with the community leaders and traditional leaders. Vaccines that we are receiving so far are safe and efficacious. That is very clear. Those are the basis, the two underpinnings of why these vaccines were authorized. Vaccine effectiveness, I say this because some journalists have approached me with that question of why are we authorizing vaccines that we hear that they are not in the field, they are not, no, the vaccines in the field are doing what they are supposed to do. They call it vaccine effectiveness, which is when you start using them in real life, you see how they behave, okay, which is not under clinical trials condition. I bet most of them are still holding their own. I mean, there's no vaccine out there that has fallen flat in the face of all these variants or in the face of large-scale usage there. I think we should be very encouraged with that. In terms of hesitancy, our position at Africa CDC is very clear. We are dealing with vaccine famine, not vaccine hesitancy on the continent. If you go into countries, many countries, whether you are in Botswana, Kenya, Morocco, you see lines and lines of young people waiting to receive their vaccine. Long, winding, meandering lines that I saw in Morocco was heartwarming, and I think I did message that through Twitter and share pictures with you. And you see that not just in Morocco, in Kenya, in Rwanda, in Malawi, Botswana, Senegal. I mean, we know that countries like in Senegal, where about 2,000 people used to be vaccinated a day, there were 50,000 people are being vaccinated a day. So I think we remain optimistic that as vaccines become available in a predictable manner, there will be more uptake of the vaccines there. I'm not so concerned with the hesitancy. Are there pockets of in the community in Africa that will continue to be resistant to vaccines? I bet there will be. I mean, it's not just unique in Africa, Europe, United States, and elsewhere. You see people that are educated, they would rather dig in and not get vaccinated. So I bet, again, let's have a social contract with ourselves that says we are going to get out of this collectively. And the only way to get out of this pandemic is to make sure I get vaccinated, to ensure my own protection, protect my family, protect my community. That's the way we are going to get out quickly.
Thank you very much, John. We have a request here from Esther Nakazi, who is in Uganda. For Mr. Masiwa, please to make available your talking points because she wants to be able to follow up on some of the issues that you raised. So we move on with our questions, and the next one is coming from Maggie Fick, who is with Reuters in Nairobi. And she says, regarding the plans to distribute Chinese vaccines in Africa through COVAX, both South Africa and Nigeria have indicated that they will not, for now, be using these shots. What is the Africa CDC's view on this? And what is the driving factor behind South Africa and Nigeria's decision, given that these Chinese vaccines have received emergency use authorization from the WHO?
I think we are all guided by the WHO emergency use authorization. We all are part of WHO, which means that WHO is a multilateral organization that we have all entrusted them to take decisions based on science on our behalf, collective behalf. So our position is clear that vaccines that have been formally approved through the emergency use authorization process by the WHO, it means that there's enough evidence to suggest that they are safe and efficacious. I cannot go in and explain, I'm not in a position to explain individual countries' behaviors because that is all a national decision.
All right, thank you. The next question is for Mr. Masiwa, and it is coming from Esther Nakazi, who is a freelance journalist in Uganda. She says, what did it take to change the Aspen contract from a contract to a licensed manufacturer? And by the time the shipment was stopped, how many doses had already been shipped to Europe?
As I pointed out earlier, a license arrangement is a commercial arrangement between two companies. Okay, we have indicated what we would like to see. The two companies have agreed that that is what they will do, they will work towards. They have made an announcement. These are big public listed companies. Aspen is listed in South Africa. Johnson & Johnson is the world's biggest pharmaceutical company. They have made the announcement, which went out last night, to say they are moving towards a licensed arrangement. So we cannot say more than that. With regards the shipments from that went to Europe, this was an arrangement between Europe and Johnson & Johnson. We were not privy to it, and it has been corrected. That is the important thing. It has been corrected, and the Europeans will be giving us 200 million doses of their own vaccines. And that's extremely generous. It's the most generous that we have for between now and December. And we appreciate that. That was done in a very cooperative manner. It's not because they feel they owe us anything. What was done was totally legal between the two companies. So I don't want to go further into it. We are happy with the status.
All right, thank you. We now go into our last question, and this is coming from Rhoda Odiambo, who is with the BBC. She says, earlier on, the Africa CDC spoke against rich countries vaccinating its young people because before Africa would be able to vaccinate its high-risk groups. So what does Dr. John think about Morocco and Zimbabwe vaccinating children between 12 and 17 years? Should they have waited longer?
So I think the question is, do we have evidence, enough data to support that we should be vaccinating younger people? In other words, it will be, I still have to see the data that says that if we vaccinate the younger age group, it's beneficial for them. In other words, if the younger age group were falling sick and being severely sick or being hospitalized, that then it would justify that in the spirit of let's keep changing our strategy based on the science that is emerging and knowledge of the virus there. I haven't seen that data yet. And if you put that on the overall scale of how do we end this pandemic? I've said earlier that the only way to end this pandemic is to vaccinate quickly and at scale everybody that is eligible so that we blunt the spread of the pandemic all over there. So now individual countries may take their decisions. That is up to them to do it based on the availability of vaccines. But again, we should not depart from the centrality of what we are trying to do, which is vaccinate at scale and at speed so that we emerge from this, or everybody emerge from this.
All right, thank you very much, John. We've come to the end of the session today. In fact, we have run out of time. So let's have... Yes, Mr. Masio.
Let me make a few quick points which are very important for us to get out there. One of the most important contributions that we have received is from the MasterCard Foundation, who, as you will recall, committed $1.3 billion towards the work of the Africa CDC, including purchasing of vaccines. Over our being financed by the MasterCard Foundation as a donation to the African member states. So let me just explain. I showed in the last presentation if you recall, a slide which shows the number of vaccines that we are getting, but each country actually gets free vaccines against its shipments. And these are funded by the MasterCard Foundation. We're extremely grateful to this gesture. They remain the only major foundation that has done something on that scale. I'm just pointing this out, that is extremely important to us. The MasterCard Foundation are also putting money into delivery. As vaccine shipments stabilize, and like I said, I can only speak into the vaccines that we have purchased, that we have contracted for. As we get the 20 million a month of vaccines coming through, what is important for us is that countries have capacity on the ground to deliver. That is training of people, setting up vaccination centers, vehicles, paying staff. All the stuff costs money, much of which was not budgeted for by our member states. Okay, and as part of our efforts, we envoys were also charged with ensuring that countries get additional money. So I'm part of a group of 7 envoys who are working. I work on supply chains, but my colleagues, such as Dr. Donald Kaberuka, Tijan Tiam, Trevor Manuel, they've been working, and we meet all the time. They were responsible for the release by the IMF of the special drawing rights. They worked on that for 12 months, and 32 billion was released this month. They report to President Ramaphosa as well. And it's important to acknowledge this work, because it has also released resources for the purchasing of vaccines by the member states. So I just wanted to point that out for everybody to just bear in mind as they see the big announcement around SDRs, to remember this is part of our collective work as the African Union to deal with this pandemic in a holistic way. Finally, the issue of anti-vaxxer and vaccine hesitancy. With us being at only 2% of our population vaccinated, the issue of vaccine hesitancy is still moot, because we have no evidence to suggest that where it exists, it is more than 30% of our population. We've met with the African health ministers, all of them in single sessions, and where everybody was present, and we asked them about vaccine hesitancy. And they have said there is only one issue here, which is vaccine supply. In Africa, the issue is vaccine supply. Even if there is loud noises around vaccine hesitancy, and we will not dismiss it, but let's get to 60%, okay? And then we worry about the 40%. But if 60% of our population right now are happy to take the vaccine, let's get it to them. That's the main thing. So because we can really throw up things in the air, but at the end of the day, our ministers told us that the issue is delivery of vaccines, okay? And we also believe now that it's not even a production issue. It is an issue of distribution. There are countries still significantly hoarding supplies, okay? We need to continue to address this and call it out for what it is, okay? So I will close my, my contribution there.
Thank you very much. Talking about hoarding supplies, just one last question to Dr. John, coming from Coletta Wanjohi, who is with FSN. She has been asking about the progress regarding the purchase of vaccines, but I think that has been adequately dealt with throughout this session. Then her final question was, are developed nations loosening up on hoarding of vaccines?
I think the answer is simple, or has been explained adequately by what Strive mentioned. I mean, you can see that the United States, the European Union, France, and others, and Germany, I mean, and you heard from Strive, are all releasing vaccines. I think we are very grateful for that. So when we come to this platform and we are critical, it's not because we want to be critical, it's because we want to see progress. It's because we are in a pandemic. A pandemic means everybody, okay, we are in together here, and we are making sure that common sense prevails, which says that we either come out of this together or we go down together, regardless of where you are in the world. Again, I will just end by, again, referring us to the situation in Israel, which I ask everybody to pay attention to it. Israel was one of the countries that vaccinated its population to scale and at speed. And they opened up the society. People were free to move around, do things, but you can see where it is. So what happened? A Delta variant was introduced in the country and then completely took over. And so again, it speaks to what I'm saying. We must come out of this together, or we are doomed together. And the quickest way to come out is to vaccinate quickly. That's all I will say.
All right. Thank you very much. We have now come to the session where our two panelists give us their summaries of the main headline points that they want people to take away today, very briefly. So let me start with Mr. Masiwa for your key points as takeaways.
Right. The international community, through COVAX, undertook to deliver for Africa 720 million doses by December. Let me repeat, 720 million doses by December. That would be just under 30% of our population. The undertaking was that they would provide finance to COVAX, and COVAX would buy. And this would be 30% or so of our population. We as Africa undertook to buy vaccines for 30% of our population. The situation that we have is the international community has not met its obligations under that understanding of COVAX. COVAX was supposed to deliver 320 million doses by August. In a letter to us that we received only yesterday, that number is 30 million doses. That's less than 10% of what was targeted. Okay, so it's important to keep tracking the numbers, okay? Because in so many numbers thrown around, we can lose sight of it. Even if the dose sharing of 200 million from the Europeans, 100 million from the Americans, set for this by December, okay, that would take us only halfway of the international community's commitment. It would be a significant improvement, but we will all have to track together over the next 3 to 4 months whether that commitment comes through. Okay. So this is very important. From our side, as the African countries, we always had made the commitment that we would start shipping what we purchase in August, and we have done so, and we will be stepping up. we've dealt with the issue with the Europeans where there were vaccines were making their way back to Europe. That's been cleared and is being cleared in an amicable and progressive manner. And we've put it to bed, and we are happy with that outcome because it also guarantees our drug substance moving forward. So those are my key issues for today. And I will continue to come and join the CDC meetings every 2 or 3 weeks to give you updates. But this is their meeting, and I will refer back to John.
Thank you very much, Dr. John.
No, thank you, Wayne. And let me keep my closing remarks to 3. One is a repetition of what I said after Strive intervention, that we should really celebrate the power of unity of purpose that has brought together a political leadership under President Ramaphosa, Strive's great coordination as the Harvard coordinator, Dr. Vera Songwe, and Benedict Orama, working like everyone around an orchestra to make this happen. This is historic, and it needs to be discussed more and promoted more. And I just want to thank you, Strive, again for your relentless efforts and your commitment in this process. We meet nearly every evening, and we speak at least 2 or 3 times a day. And he's doing this out of his own, out of truly goodwill. It's not a job that he's paid for. He has his business to run, but he has devoted the last 18 months trying to solve a problem that is a continental problem. When we talk about Pan-Africanism in modern days, excuse me, I don't know any other manner of describing it other than trying to solve this kind of a problem at continental level, as Strive has coordinated and guided all of us with President Ramaphosa. The second thing is a word of thanks to the European Union. That is, when we are at times critical, frustrated, it is because we are frustrated and we are not happy. And we express that, and we are happy that the European Union is listening. The fact that they will be releasing the 200 million doses of vaccine speaks to the spirit of solidarity and cooperation that we've always emphasized, and we are grateful for that. Lastly is that as vaccines become available, it is our collective responsibility to make sure that we engage our respective communities. Let's really not underestimate the power of one, that you as an individual can actually do a lot in your community by encouraging, spreading the right message, debunking wrong information, so that that social contract that we are asking for is actually signed. And it's a moral contract that says that if any of us are affected, all of us are affected. So let's get vaccinated as vaccines begins to roll out. It's pointless for Mr. Masiwa and the whole team to be shaking the trees, finding the vaccines, and then on the one hand, the vaccines arrive and they are not used, they're picked up there. That would not be the spirit of togetherness that we want to see. So when the founding fathers of the African Union, or the African Organization of African Union, the OAU, was created, it was around solving common problems, and that challenged them at that time. At that time, it was their struggle to liberate the continent. Today, we are facing an existential